Hi everybody. Okay, now we're going to start on our GI chapters. So there's kind of a lot in here, so I'm going to try to narrow it down for you. It starts on page 19 or 1195 of your Lippincott book. However, these first two chapters, chapter 44 and 45, should be review. It's all about assessment and then some treatment modalities. But there's a couple things I wanted to point out. Just to make sure that we're all on the same page. So some of the stuff, we're going to start in chapter 44. Some of the stuff in chapter 44 should be repeat from your anatomy and physiology days and your assessment days. But if you need a refresher, you do need to know the different sections of the GI tract. And when we're talking about the GI tract, we're talking about everything from the oral cavity all the way to the anus, all the way down. And you need to know about those different structures because there's different problems that can happen all along the way. So make sure that you know jejunum, duodenum, ileum, ascending, colon, transverse, descending, anus and rectum, mouth, esophagus, stomach. Yeah, that was the wrong order, but you know what I mean. Mouth, esophagus, stomach, small intestine, large intestines. Okay, so I do want you to know that the inside lining of the GI tract replenishes itself frequently. So about every 3 days, the inside lining of the entire GI tract sloughs off. And part of that just becomes the stool that gets eliminated. So there's constant turnover in the oral and gastric mucosa. There's also constant peristalsis to move food all the way through that system. This becomes important when your patient has constipation or diarrhea. And there's some implications with both of those that we'll talk in a little bit later. I do want to just point out some rationale behind why a person may become constipated. A couple semesters ago, I had an LPN in one of my classes, and we were talking about some causes of constipation. It was on a quiz, and she just said, oh, give more water. They need more water. And she was arguing with me. I said, well, there could be other causes of constipation. She's like, no, just give more water. They're going to be fine. Well, somewhere along the way, she had learned that dehydration can lead to constipation, which is true. However, there's a bunch of other things that can cause constipation or alterations in mobility or peristalsis through the GI tract leading to constipation. So just because somebody's constipated or they have diarrhea, you can't automatically assume the cause is one thing. You really have to increase your assessment abilities to find out, are they not moving as much? Do they not have fiber in their diet? Are they on some kind of a narcotic that leads to constipation? Do they have an ileus? Do they have adhesions? So there's really a lot more involved than just, oh, this person's constipated or that person has diarrhea. So we're going to talk about a little bit of those things, but I really want you to start thinking one size never fits all with all of our patients. So keep that in mind. Okay. So the first couple pages on chapter 44 are just how to do a good assessment of the GI tract, how to listen to the bowel sounds. Remember, you always listen to your bowel sounds first before you palpate the abdomen, because if you start mashing around and palpating the abdomen before you've listened, then you can have false findings on your bowel sounds. And you'll recall that there's your 4 quadrants that you're supposed to listen to. That's on page 1203, the 4 quadrants. And then the entire abdomen as a whole is actually divided into 9 quadrants. You do have like the liver up in there and the pancreas and gallbladder under that. The kidneys are in the back. Those aren't really part of the GI tract, but they're sort of in that, that 9 region thing. Okay. I did want to point out some diagnostic evaluations. The reason I wanted to talk about this, and this is starting at the bottom of page 1203, is because diagnostic evaluations are really, really common when there is a GI disorder, of any kind of GI disorder. So I just want you to be a little bit familiar with some of the different tests. And there's a lot of different tests they do, because GI symptoms are a very common symptom for a lot of different diseases. remember that your imaging studies, your ultrasound, your CAT scan, your MRIs, those will detect structural changes, or if there's a mass present or an abscess present or something like that. It is sort of, it's a picture into the body. Ultrasound uses sound waves, obviously. But the other kind, like the scopes, like you can have an endoscopy, which the patient will swallow through their mouth, and that is there's a light and a camera on the end of a long tube, and so the physician, or the, you know, if you're doing this as a nurse practitioner, it might be something you would do, an endoscopy, where you would go down and visualize the stomach and what's going on in the stomach. And a colonoscopy is the same thing, but just going through the rectum up into the colon. We'll talk a little bit more about that. So the other things is like an upper and lower GI. When somebody is doing an upper or lower GI, that's where they will drink a contrast like a barium or something, and then they will take pictures of the barium as it goes through the GI tract, and then they can watch for different structures along the GI tract. And upper GI is where they drink stuff. A lower GI, sometimes they have to insert stuff into the colon and then get pictures of that. And that's another way to tell if there's a stricture, if there's a fistula, because the contrast will go out. They can see the contrast leaving the colon. So those are some different diagnostic procedures that they do. It's really common. And the recommendation now is for people at the age of 50 to start having an annual colonoscopy. We found in the United States that is the best way to detect colon cancer. Just like, you know, women over the age of 40 need to start having annual mammograms. People over the age of 50 should have an annual colonoscopy. That gets moved up with a family history. So if there's a family history of colon cancer, especially if the colon cancer is showing up in younger people, typically cancer in younger people is a little bit more of an aggressive cancer, and there's a little bit more likelihood that it could be passed down, could be genetic, not always, but sometimes. And so if there's a family history, like if somebody's immediate parent had colon cancer at a young age, by young age I mean like 45 to 50, around in there, then they would have a colonoscopy, at least a baseline colonoscopy starting at age 40. It might not have to be annually after that. So when somebody does a colonoscopy, there's a prep for it, which is the prep for the colonoscopy is usually worse than the colonoscopy. And the prep for it is they drink some stuff called GoLytely, and it's kind of it's a electrolyte. It changes the electrolytes so that it empties the colon out really well. And so you have the patient drinking this GoLytely, and then they have diarrhea for about 24 hours before the colonoscopy completely empties them out. And that way, when they go in for the colonoscopy, the patient, and there's a picture of it on the bottom of page 1209, the patient lays comfortably on their side, usually their left side, always their left side, just because that's the way that the rectum kind of bends in that way, and then they insert a tube. It's probably about the size of my thumb, and it's long, and there's a camera and a light on it, and the surgeon can go in there and see what's going on, and they're looking for polyps, diverticulitis, and something that could be malignant. Diverticulitis is so like if this is your colon, a diverticulitis is an outpouching this way, kind of like a little pouch in the colon, whereas a polyp is like a little finger-like projection inside the colon. So diverticulitum and polyps, they're kind of same thing, but they're, you know, the polyps go inwards towards the colon, and diverticulum goes, you know, like an outpouching. The problem with diverticulum and diverticulitis, food can get caught in there, fecal matter can get caught in there, and they can get infected, causing diverticulitis. So that's what we're worried about in patients with have diverticulum problems. And the polyps are very common, but sometimes they can become malignant. So if the GI physician is in there doing a colonoscopy and they find a polyp, typically they'll remove it, because most polyps don't become cancerous, but if they're in there, they'll just remove it so it doesn't become cancerous. Okay, it tells you about Go Lightly and stuff on page 1210 under nursing interventions, and the rest of the small bowel studies, yeah, the rest of them are, there's another test called a dephography. I was working at U of M as a clinical nurse specialist in the GI clinic, the multidisciplinary GI clinic. So I was seeing patients in the clinic, and I'd been working there for a while. I had never in my life heard of it's called a dephogram. We call it a dephogram. So this, your book calls it a dephography or decography. This when I first heard about this diagnostic procedure, I thought, oh, good Lord, help me to never have to go through this. But the reason I'm telling you this is because if you're a nurse, you need to prepare your patient for this, because what they do in a dephogram is they will insert like barium or some kind of a thick liquid that they can watch on the monitor, and then they have a patient sit on the toilet and basically have a bowel movement in front of all these people that are watching the procedure. So as you can imagine, this has all kinds of implications to it. One, the patient has some kind of GI disorder where they need to actually have a dephogram done, and then you need to prepare the patient, because typically when somebody's having a bowel movement, it's a very personal thing. You don't really invite an audience, nor do you want an audience, but here this poor patient has to sit there and have a bowel movement in front of everybody, and what they're looking for is there constrictures, are there like sphincter problems that is causing some kind of an elimination issue or whatever. So, there's all kinds of things involved with the GI tract, and many of them are rather invasive. So you need to kind of help your patient to deal with some of that kind of stuff. So I just wanted to point some of those things out. Let's move into chapter 45. Again, this is just talking about NG tubes. You should have had this back in fundamentals and skills lab, so I'm not really going to go over that too much. I do want you to know, and just keep in mind the difference between enteral feedings, and by enteral that means your entrails, like that is the GI tract. If somebody says, your entrails, that means your mouth through your anus, all that kind of, those are your entrails. That's enteral feeding. If you have, and that's tube feeding, oral feed, any thing that goes through the GI tract is enteral. And that's including if you have an NG tube in or a Dobhoff tube and you're getting tube feedings in. Versus parenteral, and para meaning outside. So parenteral feeding, nutrition, is usually going in through a vein, and it's like TPN and lipids. So always keep in mind, when you're a nurse, you want the body to do what the body was designed to do. So if whenever possible, put your patient on oral feedings. Even if they're in a comatose or on a ventilator, a Dobhoff tube with tube feedings in is significantly better than parenteral feedings. Because enteral feedings keep peristalsis going. It aids in normal bacteria that's in the gut, so you don't have an overgrowth of bacteria. Whereas parenteral feedings, going in through the vein, you have high risk for infection because there's a lot of sugar going in there. And now the gut's not moving, so the gut's just sitting there not doing what the gut wants to do. So keep that in mind. There are some complications with enteral feeding. You'll see on table 45.3. There's some different ways. Gastrostomies and jejunostomies are tube feedings directly into the stomach or directly into the jejunum. And those are not super uncommon. You'll probably take care of several of those in your nursing career. So that's the same. You just kind of make sure that the skin around the opening is intact, no redness. You make sure that the tubes are intact and that the tube feeding is getting in as planned. Let's see, what else do I want you to know in this chapter? I guess that's about it. So that's about it for chapters 44 and 45. And then I'll stop there just because that's a short little blurb. And if you want to listen to it, great. If not, we're going to move on to chapter 46 in the next video. Okay.